Heart failure, clinical aspects, medical therapy, and emergency treatment. Clinical aspects. Number 1, localized heartbeat. Number 2, alterations of cardiac sounds, FRIDA. Number 3, heart failure, HNI, hemodynamic consequences, neurohormonal consequences, and inflammatory reactions. Type 4, types of heart failure, left and right. Medical therapy. Number 1, decrease preload. Number 2, decrease afterload. Number 3, increase contractility. Number 4, treat neurohormonal overcompensation. Number 5, treat arrhythmias. Emergency treatment, oxygen, reduce preload and afterload. So, clinical aspects. The localization of the heartbeat. On the left, this is the 3rd to 6th intercostal space. On the right is the 3rd to 5th intercostal space. The heartbeat can be increased through exercise and hypertrophy, and can be decreased from pleural fluid and a thickened chest. The alteration of cardiac sounds, FRIDA. F is for frequency. This is the pulse rate. R is for rhythm. I is for intensity. It should be strong and even, not pounding or not reduced. D is for demarcation. The first and second sounds should be distinguishable. They are not in the case of a murmur. And A is adventitious sounds. You can have an endocardial murmur caused by turbulence, such as valve deformities, and extracardial murmurs, such as pericardial friction. The classification of endocardial murmurs. So PAM 345. So in the 3rd intercostal space, this is the pulmonary artery. In the 4th intercostal space, this is the aorta. And in the 5th intercostal space, this is the mitral valve. Circulatory insufficiency is when the cardiac output is not enough. This can be due to heart failure or peripheral circulatory failure, such as decreased blood volume. Heart failure can be caused by primary heart disease or secondary cardiac changes. Cardiac output is the heart rate by the stroke volume, HR multiplied by SV. The stroke volume depends on 3 hemodynamic factors: the preload, the afterload, and the contractility. These are necessary for normal heart function. The hemodynamics consist of the preload, afterload, and contractility. For the preload, it's determined by the venous blood flow into the heart. The strength of the contraction increases with the original length of the cardiac muscle. So when the heart is overstretched, there is not much contraction. The afterload is the force against which the heart has to contract to eject blood. The pressure during ejection is caused by decreasing volume. The cardiac output decreases with resistance, i.e. afterload. Afterload increase is always detrimental for the cardiac function. For contractility, the ideal heart rate is between 60 to 120 in dogs, but if it's higher, around 180 to 250, there's not enough time for diastolic filling of the ventricles. The neurohormonal consequences. So decreased blood pressure causes a high sympathetic tone. A high sympathetic tone increases renin synthesis. Due to the high sympathetic tone, renin is produced and it acts on the angiotensin. Angiotensin 2 promotes the synthesis of aldosterone, which causes sodium and water retention. Since the renin-angiotensin system is permanently activated, this causes an increased heart rate and then there's an inefficient amount of oxygen and energy supply to the cardiomyocytes despite the increased demand. Angiotensin 2 and aldosterone not only have a vasoconstrictive effect, but they can cause myocardial fibrosis, which leads to a huge inflammatory response. This can cause cardiac cachexia and decrease myocardial contractility and the release of free radicals. When the heart is not receiving normal oxygenation, there's a high chance of free radical formation. The free radicals are reactive molecules with unpaired electrons. They further decrease the contractility of the heart, and they can cause cell death and apoptosis. The types of heart failure. So there can be left-sided and right-sided heart failure. Know that sooner or later both sides will become affected. In left-sided heart failure, this leads to congestion behind the left side of the heart. So behind the left ventricle, you have the left atrium, and then the pulmonary veins, which can cause pulmonary edema. In right-sided heart failure, receiving blood from both the vena cava cranialis and the vena cava caudalis can cause hepatomegaly and ascites. Left-sided heart failure is usually found in a suffocating animal. You can see tachypnea, dyspnea, worsening of cough, pulmonary edema, pleural fluid in cats only, and cerebral hypoxia, and mild prerenal azotemia. In right-sided heart failure, which is seen in hepatomegaly and ascites, you can find jugular distension due to the congestion of the vein, and a positive hepatojugular reflux by putting pressure on the liver causes distension of the jugular vein, and congestion of the abdominal organs such as the liver, and ascites, pleural fluid, and so for treating congestive heart failure, the aim is to treat the cause, relieve the symptoms, and to stop and slow the progression. So a conservative treatment is giving taurine, supplementation, and drugs. Then you can do surgery, such as close the PDA or do a pericardectomy, or catheterization, such as balloon dilation of the stenotic orifices, vessels, and putting in a pacemaker in severe bradycardia. The tactics are to decrease the preload, decrease the afterload, increase contractility, and treat the neurohormonal overcompensation and treat arrhythmias. So number 1, decreasing the preload. You give loop diuretics, such as furosemide, which is the main one, and torsemide. They inhibit sodium, potassium, and chloride, the transporters in the loop of Henle, and they're dose dependent, so the more you give, the higher the diuresis. Number 2 is decrease the afterload. This is by dilating the arteries. So you give arterial dilators such as amlodipine and pimobendan, which is a calcium sensitizer. To increase the contractility of the heart, you give calcium sensitizers such as pimobendan. They increase the contractility and they decrease the preload and the afterload. You can also give digoxin, which is a sodium-potassium pump inhibitor. It promotes calcium influx, but it could cause arrhythmia, which means it's not as safe as pimobendan. And to decrease neurohormonal compensation, add spirolactone. It prevents the aldosterone escape. And the last part is emergency situations. So do the diagnosis, give oxygen and reduce the preload and reduce the afterload. Give a diuretic and pimobendan to tick all the boxes. When treating chronic congestive heart failure, give furosemide in the smallest effective dose when it's long-term, give pimobendan as a vasodilator, and decrease the neuroendocrine overcompensation by using ACE inhibitors and spirolactone. Changes in the diet should be giving potassium, magnesium, and vitamin B, give antioxidants, and avoid severe salt restriction as it activates the renin-angiotensin system, and give taurine, carotene, arginine supplementation.